Dental medicine typically operates within strict borders. A patient presents with severe tooth wear, joint pain, or muscle fatigue, and the clinical response isolates the treatment to the teeth, the temporal mandibular joint, or the muscles of mastication. But pathologies like severe bruxism, a narrow, high-vaulted palate, or a retruded mandible rarely occur as isolated developmental errors. They are secondary physiological compensations. When the body struggles to maintain an open airway during sleep, the autonomic nervous system triggers a fight-or-flight response, forcing the craniofacial structures to mechanically adapt to keep oxygen flowing. To accurately diagnose these structural failures, clinicians must evaluate the craniofacial complex through an airway-centric lens. Treating dental symptoms without addressing the airway leaves the primary driver of deformation active. This increases the likelihood of mechanical relapse and ignores the patient's persistent cardiovascular and neurological strain. The human face develops through a feedback loop where functional airflow physically shapes the growing skeleton. Under normal conditions, nasal breathing applies continuous pressure that drives the maxilla and mandible forward. When a patient becomes an obligate mouth breather, that pressure is lost, resulting in a downward, clockwise growth rotation of the entire facial structure. To understand how this structural collapse occurs, we have to map the physical resistance points by descending from the nares all the way down to the trachea, isolating 5 distinct zones of obstruction. Tracking this descent provides a strict mental model for identifying where airflow aids resistance and exactly how the jaw and teeth deform to compensate for that blockage. Locating these 5 defect zones enables clinicians to move past temporary fixes and address the precise anatomical origins of craniofacial collapse. The descent begins at the upper valve, the nasal cavity. Normal nasal breathing filters the air and stimulates the paranasal sinuses to produce nitric oxide, a crucial gas that promotes vasodilation and systemic immune defense. When navigating this space, Poiseuille's law dictates the physics of respiration. This graph illustrates the mathematical relationship. Even a minute reduction in the radius of the airway causes an exponential spike in airflow resistance. Defect 1 occurs exactly here: nasal airway obstruction. Structural blockages like a deviated septum, enlarged turbinates, or nasal polyps force the patient to abandon nasal breathing entirely. Defect 2 sits just posterior to the nasal cavity: adenoid hypertrophy. Particularly in pediatric patients, enlarged adenoids represent the primary physical block in the nasopharyngeal space. The immediate mechanical consequence of these upper airway blockages is a shift in rest posture. To allow air to enter through the mouth, the tongue must drop away from its natural resting position against the hard palate. This triggers a severe skeletal fallout. Without the tongue providing outward counterpressure, the constant inward forces from the cheek muscles squeeze the developing maxilla into a constricted, narrow arch. Clinically, this presents as adenoid facies, characterized by a long lower face, a narrow alar base at the nose, and a high-vaulted V-shaped palate. Because upper valve failure directly causes this V-shaped maxillary constriction, restoring normal function requires structural intervention. Localized palatal expansion becomes the necessary geometric fix to recreate the lost nasal volume. Descending past the soft palate, we enter the middle airway. Clinicians assess this region using specific screening tools, measuring tonsil hypertrophy with the Brodsky scale and evaluating tongue position with the Mullen-Patty index. This brings us to defect 3, oropharyngeal obstruction. This occurs when hypertrophic tonsils and a collapsing soft palate physically narrow the air column. Immediately below that lies defect 4, hypopharyngeal obstruction. Here, the blockage is driven by the base of the tongue due to macroglossia, an abnormally large tongue, or a posterior tongue posture that crowds the airway. As airflow squeezes through these narrowed middle valves, it accelerates. According to the Bernoulli principle, this increased velocity causes a drop in pressure, creating a vacuum that forces the flexible tissues of the airway to collapse, the mechanical driver of obstructive sleep apnea. This scan shows how focal encroachments amplify this collapse. Focusing on the cross-sectional and axial slices, a soft tissue tumor clearly encroaches on the pharyngeal wall, drastically reducing the cross-sectional area to less than 88 square millimeters and severely driving up airway resistance. When the airway collapses, the dental response kicks in. Nocturnal bruxism, the grinding of teeth, is a sympathetic nervous system reflex initiated by the brain to force the airway open. Biomechanically, it is a survival tactic. The muscles of mastication fire, thrusting the lower jaw forward to physically pull the tongue base away from the posterior pharyngeal wall. You can identify this reflex clinically. Patients present with extreme occlusal wear, scalloped borders along the tongue, and chronic cervical neck pain. In a patient with compromised breathing, bruxism is a life-saving mechanism. Suppressing this motion by locking the jaw into a flat acrylic splint traps the mandible backward, directly worsening the underlying apneic events. Stripping away the soft tissues reveals the ultimate limiting factor. Defect 5. Skeletal airway defects. The bones themselves establish the boundary conditions for respiratory volume. A severe skeletal deficiency, specifically a retracted maxilla or a retrognathic mandible, creates a structural cage. It physically boxes the tongue in, forcing it backward into the pharyngeal space, regardless of soft tissue health. This lateral sagittal scan reveals a direct correlation. The deficient skeletal phenotype severely constricts the airway column, reducing respiratory volume. Below, the same constriction manifests dentally. Severe tooth crowding is a geometric symptom of jaw bases failing to properly develop. In pediatric patients, this skeletal defect presents an immediate crisis. Infants with a severely hypoplastic mandible exhibit stridor, struggle to feed, and endure massive sleep disturbances as they fight for oxygen. When the skeletal foundation is physically too small, the airway is trapped in a permanent state of collapse. Soft tissue removal, like a tonsillectomy, is insufficient. The condition requires surgical bone-level expansion. For children under 4 exhibiting severe mandibular hypoplasia, a strategy of watchful waiting is exceptionally dangerous. Early severe hypoplasia does not resolve on its own. It locks the airway into a compromised state and permanently alters the trajectory of all subsequent facial growth. The definitive intervention to rescue these severe cases is mandibular distraction osteogenesis. These diagrams illustrate the surgical phase. An osteotomy creates a precise break in the mandible for distraction hardware. Turning the device daily pulls the bone segments apart, stimulating new bone formation to physically lengthen the jaw and expand the dental arch. The physiological payoff is immediate. As the mandible lengthens, it pulls the attached base of the tongue forward, instantly opening the pharyngeal airway and protecting the bone's natural growth centers. Early distraction osteogenesis establishes the necessary bone volume for a functional airway. This intervention provides the structural foundation required for a healthy growth trajectory. Returning to the clinical setting, the hierarchy of the craniofacial matrix is clear. Functional airway dictates facial growth, and that facial growth dictates dental occlusion. This demands a shift in diagnostic protocol. Clinicians must look past the surfaces of the teeth and actively screen the geometry of the airway using cone beam computed tomography volumetrics. Structural risk can be directly quantified. For example, an adult intermolar width measuring less than 38 millimeters is a strong indicator of a constricted palate and a highly compromised airway. Managing these complex structural failures requires a multidisciplinary approach, integrating the expertise of otolaryngologists, dedicated sleep physicians, and myofunctional therapists. However, the dental professional operates as the primary gatekeeper, uniquely positioned to detect all 5 of these anatomical defects during routine clinical observation. Identifying these structural deficiencies early shifts the clinical priority from aesthetics to the prevention of systemic disease. For pediatric patients with skeletal hypoplasia, this diagnostic move supports the trajectory of lifelong health.